Hello everyone, welcome back to Communicable Disease, and I hope you all are doing very well. Before we begin, let me remind my dear students that the contents of this channel are only to supplement your knowledge, not to replace the regular online and offline classes in your institution. So please attend your classes and do not miss them. Also, if you like our contents, please subscribe to our YouTube channel, like the videos and share these videos with your friends, with your batchmates, with your juniors. Also, if you are a teacher, then with your students. Please follow our Facebook page and the link will be given in the description. In last couple of months, we discussed about basic biostatistics, sampling techniques, etc. So I think this is the best time that we return to communicable disease, and the topic that we have selected today is one of the most common communicable diseases in our country or in any developing country like India. Now this is a huge topic, and because of that this whole lecture will be divided into multiple parts and the videos will be uploaded on our channel in subsequent weeks. Now before I begin, I must mention something, and this is a request to all my viewers also. The tuberculosis and the national program related to tuberculosis is so frequently changing. So whatever I shall be discussing today, a lot of things may change by the time you will appear in your exam or interview. So please keep yourself updated with the national program, especially the changes related to it. Whatever I shall be talking today is the thing that have been updated till the year of 2021, early 2022, like that. So if you are watching this video in late 2022, 2023, 24 like this, I'm pretty sure by that time lot of things will be changed, and please keep yourself updated so that you do not give wrong answers during your exam. And I do not want my students to have their numbers deducted because they are not updated. So with this we shall start the first part of tuberculosis. We know that tuberculosis is caused by a bacteria, that is Mycobacterium tuberculosis. This bacteria was first isolated and discovered by Robert Koch in the year 1882. He was a German microbiologist, and that is why it is also known as Koch's tubercle, and the disease is sometimes called Koch's disease. This disease primarily affects lungs and it is known as pulmonary tuberculosis. But apart from lung, it can also affect other organs like intestine, meninges, bones and joints, limb glands, skin, etc. And in these cases, they will be considered as extrapulmonary tuberculosis. Now, in this context, I must mention something, that whenever tuberculosis affects pleura, which is basically a cover or layer or membrane around the lung, and it does not affect the lung parenchyma, so pleural tuberculosis will be considered as extrapulmonary tuberculosis, not pulmonary tuberculosis. So please remember this. This is often asked as a MCQ. The disease is usually chronic, so that means whenever a person suffers from tuberculosis, generally the disease persists for a very long time, so of long duration, and people may have different clinical manifestations, so varying clinical manifestations. It is estimated that about 1/3 of the global population is infected asymptomatically with tuberculosis. So whatever number of people we have right now all over the world, 1/3 of them are infected by the bacilli and they do not have any signs symptoms. Always remember that infection does not always mean the person has the disease. The person may not have any sign symptom, so it can be asymptomatic disease, or even sometimes the person can have very strong immunity so that the disease does not occur at all. The thing is, 1/3 of the global population at present is infected by the bacilli. Now all those who are infected, about 5 to 10% of them will sometime develop the disease clinically during their lifetime. Now coming to the problem statement, here I have data for 2019 which is given in the book of Park, the latest edition. Again, I have not spent much time on the problem statement because by the time you will watch this video, these statistics may have already changed. So you may have new data, new information. So the data I have here is from 2019, and an estimated 10 million people had tuberculosis in the year 2019. It is estimated that 3.3% of the new cases or 18% of the previously treated cases had MDR or RR-TB. So MDR means multi-drug resistance TB and RR means rifampicin resistance tuberculosis. So that means in the year 2019, of this 10 million people, those who were new cases, 3.3% of them, and those who were previously treated cases, 18% of those people had drug resistance tuberculosis like MDR-TB or RR-TB. Geographically speaking, most people who developed tuberculosis in 2019 were from Southeast Asian region, that is 44%. This was followed by African region 25% and Western Pacific region, that is 18%. India is the highest burden country with 26% of all cases, about 2.64 million cases, and this is the global scenario. So as you can see, we have a huge burden of tuberculosis in our country, and we are the biggest contributor of TB case load globally, that is 26% of all cases. Agent factors. So Mycobacterium tuberculosis is the bacteria that causes tuberculosis. It is a strict aerobe and thrives best in tissue with high oxygen tension, and that is why this bacteria is more commonly found in the apical part of the lung or in the upper lobes of the lung. They are slender, rod-like, non-motile, intracellular bacteria neutral to gram staining. So that is why if we do gram staining, we may not be able to identify the bacteria. The source of infection, we have human source, most common source being the human case whose sputum is positive for tubercle bacilli and who has either received no treatment or has not been treated fully. So a case of tuberculosis who has the bacteria in his sputum. Also, the person has not either started the treatment or he has not completed the treatment fully. So that is a case of tuberculosis and he is the human source. So that means a person suffering from tuberculosis who has tubercle bacilli in his sputum without any treatment or with incomplete treatment is the human source. He will spread the bacteria to other people. Bovine source, usually infected meal. Now the thing is, in our country, since we have this custom or practice, better to say practice, of boiling the milk before consuming, that will kill the bacilli. So that is why this is very uncommon in a country like India, that tuberculosis is being spread by infected milk. Coming to the host factors, different factors of the host that can actually help in spread of the disease or causation of the disease. For example, if you are talking about age, there is sharp rise in incidence from childhood to adolescence in developing countries. So as the age increases, there is also increase in incidence. Male are more susceptible to the disease than female. This is because of the occupation of the males. They are mostly involved in outdoor activities, whereas in our country still women are mostly either homemaker or unemployed, so they stay inside the home and they are not exposed to the environment. So that is why males are more susceptible. It is not a hereditary disease, but twin study has revealed there is some inherited susceptibility. Nutrition is very important. A malnourished person or a malnourished child having compromised immunity or suppressed immunity can be very susceptible to develop the disease. There is no inherited immunity. Man acquires immunity either by natural infection, that means he suffers from tuberculosis, or by BCG vaccination. So this BCG vaccination is given to a child. The details of BCG vaccination will be discussed in future video. Mode of transmission, so this is a respiratory infection and it is spread mainly by droplet infection and droplet nuclei, and it is not transmitted by fomites. Coming to case definitions. So this is very important. We have bacteriologically confirmed case and clinically diagnosed TB case. So bacteriologically confirmed TB case is one from whom a biological specimen is positive by smear microscopy, culture or WHO approved rapid diagnostic test like expert MTB or RIF. So what does it mean? If a person we are suspecting to have tuberculosis and from him we collect a specimen. If this specimen is positive for the bacilli, either by microscopy or by culture or by some rapid test as I mentioned earlier, that means we could identify the bacteria in the specimen. So we can say it is a bacteriologically confirmed TB case. Sometimes the criteria for bacteriologically confirmation is not fulfilled, but the clinician may diagnose the patient as a TB case based on certain criteria. So maybe some X-ray abnormalities are found which are suggestive of tuberculosis, or maybe if biopsy is taken from a particular sample, the histology is suggestive. Also, in case of extrapulmonary tuberculosis, certain investigations may be suggestive of tuberculosis. So in all these examples or cases, the person is not bacteriologically confirmed because we are not retrieving any bacteria or bacilli from the specimen. Rather, we are making this diagnosis based on features or findings which are suggestive of tuberculosis. For example, X-ray or histology, etc. So these are known as clinically diagnosed TB case. Now, if we have bacteriologically confirmed case or clinically diagnosed case, they can be further classified based on different criteria. For example, anatomical site of the disease can be pulmonary or extrapulmonary. This is the part we already discussed. History of previous treatment. So new case. Who is a new case? A person who has been diagnosed for the first time and he has never taken a drug, okay, anti-tuberculosis drug, or the person was previously diagnosed and maybe he started anti-tuberculosis drug but he did not continue the medication beyond 1 month. So that is considered as a new case. What is a relapse case? Relapse case means the person he started medication earlier because he was diagnosed earlier. He completed his medication and after that at the end of treatment he was declared cured. Maybe he developed tuberculosis again, maybe after 6 months, after 1 year. So in that case this is called as or known as relapse case. Treatment after failure means the person was diagnosed earlier, he completed his course of treatment and at the end of treatment it was found that there is still presence of bacilli or bacteria in the specimen. So that means treatment is failed here. So treatment after failure. And treatment after loss to follow-up. In this case, the person was diagnosed earlier, he started treatment, he continued treatment for a certain period of time, which is definitely more than 1 month, and after that he discontinued taking the drug for at least 2 consecutive months. So in that case they can be considered as defaulter. Sometimes patients are not found and because they cannot be tracked, they are just lost. This is known as loss to follow-up. So treatment after loss to follow-up. So all these are different classification based on previous treatment. Drug resistance based on drug resistance. So the bacteria can be drug sensitive. So first line drug should work on this bacteria. There can be monodrug resistance. So any one first line drug is resistance. Polydrug resistance is 2 or more than 2 drugs are resistance. But if there are 2 or more than 2 drug resistance, isoniazid and rifampicin together cannot be resistant. If both isoniazid and rifampicin are resistant, that means H and R, it is known as MDR, that is multi-drug resistance tuberculosis. XDR is extensively drug resistance tuberculosis, where there is resistance to isoniazid and rifampicin. Along with that, second line injectables like amikacin, kanamycin, capreomycin, and also fluoroquinolones like moxifloxacin, gatifloxacin, etc. There can also be rifampicin resistance. HIV status of the patient. So the person can be HIV positive, or he can be negative to HIV infection. Sometimes his HIV status may not be known, so unknown status. So these are different classification based on different criteria. These are very commonly asked during viva tables, so I will request my viewers to remember all these things. Coming to the clinical features, here we shall be focusing mainly on the pulmonary tuberculosis. Extrapulmonary tuberculosis will not be covered in our topic or in our videos or discussion. So what are the clinical features of pulmonary tuberculosis? So these are the signs and symptoms. Remember, these are the classical signs and symptoms. Not necessarily every patient of pulmonary TB will come with all these symptoms. So there can be coughing up of blood, which is also known as hemoptysis. There can be fever, pain in the chest, chills, loss of weight, which is very important, night sweats, long-term cough, so chronic cough, no appetite, so loss of appetite can be there, and fatigue. So all these are more or less the classical symptoms of pulmonary tuberculosis. Often the patient will come to us with complaint of a chronic cough, maybe about 7 days, 10 days, 14 days like this. He will also say that sometimes along with cough there is fresh blood coming out during coughing. There is fever, the person has lost weight recently, and at night during the bedtime he sometimes sweat. So all these symptoms will give the suspicion of pulmonary tuberculosis. Now going further into the program related topic, the first national program that was launched in our country against tuberculosis was National Tuberculosis Program in the year 1962. But after a few years, we could identify a lot of problem with this program. For example, there was unacceptably low treatment success rate, and because of that there was high death rate and high default rate. As I mentioned earlier, what does default mean? Means the patient will start taking medication and after that he will discontinue taking medication. And all these things will ultimately develop to spread of multi-drug resistance tuberculosis. Then in the year 1993, RNTCP came into act. What is RNTCP? Revised National Tuberculosis Control Program. It adopted the internationally accepted DOT strategy. So what is DOT strategy? Directly observed treatment, short course chemotherapy. We shall discuss it in details later. It also adopted smear microscopy as the gold standard test for diagnosis and strengthening of the drug supply. So RNTCP also tried to ensure that drug supply is uninterrupted. That means all patients must receive their drugs so that they do not have to discontinue taking the medication because there is no supply of drug. Now the initial objectives of RNTCP in India were to achieve and maintain a TB treatment success rate of at least 85% of new sputum positive patients. Also to achieve and maintain detection of at least 70% of estimated new sputum positive people in the community. So what are the objectives? The initial objectives are like, we have to detect at least 70% of the new sputum smear positive cases in the community. So if there are about 200 new sputum smear cases in the community, we need to identify at least 140 of them, that is 70%. The more we get, the better it is, but it has to be at least 70%. Also, those who have been identified, when the treatment is started, we must ensure that there is at least 85% treatment success rate. That means by the time they will finish their treatment, they will not have any bacilli in the specimen. So these are the two initial objectives of RNTCP: 70% of detection and 85% of treatment success rate. After that, there was National Strategic Plan for Tuberculosis Elimination 2017-2025. So as the number of TB cases increased gradually, we are still having a lot of cases, and as I mentioned earlier, we are the highest contributor to the TB case burden globally. So that is why we have to be more strict towards the control program, and that is why we have rather taken the step towards elimination of the disease from our country. So National Strategic Plan for Tuberculosis Elimination had a vision to have TB-free India with zero deaths, disease and poverty due to tuberculosis. And the goals were to achieve a rapid decline in burden of TB, morbidity and mortality while working towards elimination of TB in the year 2025. So as you can see, the vision and goal are specific, and we are just trying to reduce the number of cases, reduce the number of deaths from TB, and reduce the number of people who are suffering from poverty due to tuberculosis. And we are trying to eliminate tuberculosis in India by the year 2025. Always remember, we must set a target. We must have a timeline. Only if we have set a target or timeline, we can at least reach towards that as close as possible. Now coming to the targets, so we have set a few targets for National Strategic Plan for Tuberculosis Elimination. So we have the baseline data for 2015 and 2020 and the target for 2023 and 25. So the first is to reduce estimated TB incidence rate. So these are the impact indicators, that means the long-term indicator. So TB incidence rate has to be reduced. In the year 2020, it was 142 per 1 lakh population, which has to be reduced to 44 or even lower than 44. TB prevalence rate per 1 lakh population to be reduced from 170 in 2020 to less than 65 in 2025. To reduce estimated mortality, that means death due to tuberculosis per 1 lakh population, it is 15 in the year 2020, which has to be reduced to 3 or less than 3 by 2025. And also to achieve zero catastrophic cost for affected families due to TB, which has to be zero. Now we must understand what is catastrophic cost due to tuberculosis. It means whatever is the income of a family, if more than 20% of that income is spent on direct or indirect cost due to tuberculosis, maybe diagnosis, treatment, or even communication cost, or any expenditure for taking the patient to the hospital, to the diagnostic center, whatever. So any cost related to tuberculosis, if the amount is more than 20% of the family's income, then it is considered as catastrophic cost. So these are the impact indicators. We also have outcome indicators. So again, we have the baseline data for 2015 and 20 and the target for 2023 and 25. So what are the indicators here? Total TB patient notification, total patient private providers notification, so multi-drug resistance or rifampicin resistance tuberculosis patient notified. So how many of the drug resistant tuberculosis patients being notified? Proportion of the notified TB patients offered drug sensitive test, proportion of the notified patient initiated on treatment, treatment success rate among notified drug sensitive tuberculosis and also drug resistance tuberculosis, proportion of identified targeted key affected population undergoing active case finding. So 100%. So that means all the targeted key population should be approached for active case finding. Proportion of notified TB patients receiving financial support through DBT, and proportion of identified eligible individuals for preventive therapy initiated on treatment. So all these are outcome indicators. The 4 strategic pillars for movement towards elimination, TB elimination, is DTPB, that is detect, treat, prevent, build. So what do we do for detection? find all drug sensitive and drug resistant tuberculosis cases with an emphasis on reaching TB patients seeking care from private providers and undiagnosed TB in high risk population. Treat, initiate and sustain all patients on appropriate anti-tubercular treatment wherever they seek care with patient-friendly system and social support. So these first 2 points are very important. We have to detect as many cases as possible, special emphasis on target population, high-risk population, etc. And also whenever we detect the cases, we have to start and also we have to continue or sustain the appropriate anti-tuberculosis treatment. Prevent the emergence of tuberculosis in susceptible population and build and strengthen enabling policies, empowered institutions and human resources with enhanced capacities. So unless we have proper infrastructure, adequate manpower, money, material, etc., it is impossible to continue such a huge national program in a huge country like India. So that is why building the whole system and also sustaining, strengthening this system is very important. Under our NTCP, for all the states and UTs, that is union territories, the target set were at least 70% detection rate of the new sputum severe positive cases and also at least 85% cure rate. So this is the part that I already discussed earlier. What do we do in our real life situation? We set a target for us. Say I want to achieve 80% mark in mathematics exam. So in the next exam, if I somehow get 80% mark, then I can only try to achieve even higher marks in the next exam. So next time I can set a target of 90% mark. So that means whenever I fulfill a target, I can set the next target at higher level. So similarly, when some of the states or all the states will fulfill this target and they will achieve 70% detection rate, 85% cure rate, they can also set a new target of at least 90% detection rate and at least 90% of cure rate. There are some other targets by different strategies, goals, etc. Like WHO NTB strategy, they are trying to achieve global elimination of tuberculosis by the year 2035. Sustainable developmental goal talks about to end TB by the year 2030. National Health Policy 2017, Government of India have targeted to eliminate tuberculosis and its transmission by the year 2025. End TB mission by Ministry of Health and Family Welfare, trying to control and achieve zero tuberculosis by the year 2020. So as you can see, different global and national strategies, plans, etc. have different target, but more or less we are trying to eliminate the disease as early as possible. Next is NTEP, that is National Tuberculosis Elimination Program. So in the first part of 2020, the central government has renamed the RNTCP as National Tuberculosis Elimination Program. So what happened here? The revised National Tuberculosis Control Program was renamed as NTEP. So control program became elimination program. So we are being more stringent and more focused regarding the elimination of the disease from our country. So that is why this name was changed. This is the letter, the subject being change of name of revised National Tuberculosis Control Program to National Tuberculosis Elimination Program. So this was sent to all the state chief secretaries of states and UTs. Earlier I mentioned DOTS, that is directly observed treatment short course chemotherapy. So let us understand what DOTS is. The first part is directly observed treatment. That means whenever a person is diagnosed with tuberculosis, he is supposed to start the anti-tuberculosis drugs or ATDs. He should receive the medicines from DOT center. So nearest DOT center he has to visit. During the first 2 months of his treatment, which is known as intensive phase, he is supposed to take this drug in front of the person who will be providing him the drug. This person is also known as DOTS provider. So the person or the DOTS provider will actually supervise the patient taking his drug on daily basis during the intensive phase. So that is why this is known as directly observed treatment. Then there is short course chemotherapy. Before RNTCP, when the duration of tuberculosis was very long, a person had to continue the treatment for over 1 year, sometimes 1.5 years or 2 years, like that. But since RNTCP was introduced, the duration was significantly shortened. Right now, any person having drug sensitive tuberculosis has to take the medicines for 6 months. So as you can see, the duration of the treatment has been reduced significantly. So that is why short course chemotherapy. Coming to domiciliary versus hospital based treatment. Again, in earlier days, whenever a person is diagnosed with tuberculosis, he had to be hospitalized. The person will be treated in the hospital. Now there were a lot of problems. Number one, the duration of the treatment was very long, as I just mentioned. So the person may had to stay in the hospital for over a year. So that is a long period of time. And along with that, there is lot of cost or expenditure, direct or indirect, related to the hospitalization. Also, there is some chance of hospital acquired infections whenever a person is hospitalized for such a long time. It was found that there is no added advantage of hospitalizing a TB patient over the patient staying at home and receiving the drug from the home. So that is why with introduction of RNTCP, the domiciliary treatment was followed. That means the patient would stay at his home. He has to visit to the nearest DOST center to collect the medicines daily during the intensive phase and monthly during the continuation phase. Now coming to the state level organization. In the state level, we have State Tuberculosis Office, where we have State Tuberculosis Officer, so STO. So for individual state or for every state, we have one State Tuberculosis Officer. There is a wing in State Tuberculosis Office where different training programs are run. This is known as State Tuberculosis Training and Demonstration Center. These training are for the district level officers or laboratory technicians, laboratory supervisors, treatment supervisors, or any person who are directly or indirectly related or connected with the tuberculosis control program. And also in the district tuberculosis center, we have district tuberculosis officer. So under a state, if there are multiple districts, there are also multiple district tuberculosis officer. There is also tuberculosis unit or TU in the district tuberculosis under the district tuberculosis center. So under one DTC, there are multiple TU, and in each TU we have a medical officer, a senior treatment supervisor, also known as STS, and senior lab supervisor or STLS, senior TB lab supervisor. So this is a very commonly asked question. Who are the personnel present in tuberculosis unit? We have to give this answer. There are also microscopy centers and treatment centers, and we have DOTS provider who provide the drug to the patients. So this is the state level and district level organization in our country. Coming to the laboratory network. So we have the laboratory network in the national level, district level, state level, etc. In the most peripheral level, we have the DMCs, that is the designated microscopy centers, which are run by laboratory technicians. They basically test the sputum samples under microscope and report to the TU, that is the tuberculosis unit. So under a TU, there are multiple DMCs. Again, district tuberculosis center, they have multiple TU under them. District tuberculosis center is again supervised by IRL, that is Intermediate Reference Lab, and or Culture and Drug Sensitivity Lab, which is basically present at the state level. And generally in the medical colleges we have the IRLs. If the size of the state is huge, or you can say there are a lot of population, in that case there may be more than one IRL in the state level. Otherwise there is generally one IRL for every state. And at the topmost hierarchy we have the National Reference Lab at the central level or the national level. At present we have 6 national labs at Chennai, Agra, Delhi, Bangalore, Bhubaneswar and Bhopal. So this is kind of important. We often ask this to our students. So at the most peripheral level there are designated microscopy center which are controlled by the tuberculosis unit, which are again being controlled by district tuberculosis center. Then at the state level we have IRL, and then at the national level we have the NRL. Now this is the proposed NTEP structure. As you can see, and there is central TB division, state TB cell and district TB cell, under which there are TB unit. There are also involvement of medical college, district hospital, sub-district hospital, community health center, primary health center, etc. Also different laboratory facilities have been mentioned here. So you can pause the video here and look at the whole thing. And with this we conclude the first part of tuberculosis. In the subsequent videos we shall talk about the regimen, the old regimen and the current regimen. We shall talk about the drug sensitive tuberculosis and drug resistance tuberculosis, different drugs, newer drugs, also newer initiatives. So if you like our video, please subscribe to our channel and also share this video with your batchmates, juniors and friends from other colleges. We also have our Facebook page that you can follow. The link is given in the description. Take care and we shall see you in our next video.